because there are some people that said they can't attend, but they'd still like to see it. And then we will put that up somewhere on the web for people to be able to have access to it. So first, I want to thank everybody for being supporters of the American Council on Science and Health and joining our Jonas Salk Society. Alex Berezow, Dr. Alex Berezow, is our first speaker. We hope to have these every month moving forward with a different expert each time. Alex has a PhD in microbiology. He's a science writer, and he's a public speaker who specializes in debunking junk science for ACSH. He's also an analyst at Geopolitical Futures, although that tenure is ending at the end of this year. He was primarily brought on by them to cover the coronavirus and COVID-19. He's a featured speaker at the Insight Bureau and a founding editor of the Real Clear Science page. Alex joined ACSH as a senior fellow in 2016 and was promoted to vice president for scientific communications in 2018. He's a prolific science writer whose work has appeared in multiple outlets, including the Wall Street Journal, CNN, BBC News, The Economist, Forbes, Scientific American, and USA Today. In fact, he had 2 editorials in USA Today this year. He's also a board of contributors to the USA Today. He writes a monthly column for the Puget Sound Business Journal, and additionally, he has authored and co-authored 3 books: The Next Plague, How Science Will Stop It, and The Little Black Book of Junk Science, and Science Left Behind. By the way, The Little Black Book of Junk Science has been distributed by a friend of mine to 30 key members in Congress, and one of them has already read it and is recommending that people visit ACTIA if they really want to know what's going on in science and health. So we're very proud of that. Alex has spoken on a wide variety of audiences about science, from graduate school seminars and church congregations to national TV and radio programs. He's regularly featured on the Kirby Wilbur Show, a Seattle radio program, and does a segment called Real Science with Dr. B. He also has a video that he does debunking science that's actually worth looking for on the web. It's quite amusing. Alex's biggest things this year have turned out to be his work on air purifiers and hand sanitizers, and those articles have made him somewhat of a celebrity in countries like Singapore, India, and Indonesia, where they consistently write about them.
I can't tell you how it's been a lifelong dream to be a celebrity in Singapore. So
Alex is going to present a slideshow, and that will be sent to everyone afterwards, so you don't need to bother taking notes if you don't want to. Anyway, I guess I will go ahead and turn it over to Alex.
Thanks, Tom. I personally want to thank all of you for being here. ACSH doesn't exist without you guys. And so we thought, how could we reward some of our finest donors with something a little special? And we came up with the idea of having these monthly talks. And the idea is that you get direct access to our experts, to me, to Chuck Dinnerstein, and to Josh Bloom. And you can ask us anything you want. If you want to sit here and talk about, why the Seahawks aren't performing as well as they really ought to be this season, whatever you guys want to talk about is fair game. I'm going to start off with a little 10, 15-minute presentation. And that's just meant to get the conversation started. And then you guys can fire away, ask whatever you'd like. If it's COVID related, that's the topic for today. Great. If it's not, that's fine too. This is just a service we're doing for you guys because we're so appreciative of you. And we just wanted give you the opportunity to ask whatever you want. And so also you don't need to wait to ask questions. If I bring up a slide that you want to ask about, fire away. So Tom, how do you handle that? Is there a way for them on their end to ask a question right away?
All they have to do is unmute. If you go up to the upper right corner of your screen, you can see a little blue button that says unmute, and you can
Yep.
push that, and then you can talk as well.
Do you guys all see that? You're all automatically muted just by default. And then if you want to unmute, you can just unmute yourself. There's a button that you can push to unmute to. Alternatively, there's a chat feature at the very bottom of the screen. You can see this button says chat. You can click on that. And then if you write something, I can see it. That way I can see a question that comes up in the chat screen. So if you don't feel like talking, that's another way to get the message.
And when
to
you're
me.
chatting, you can chat to everyone, or you can chat to a particular participant as well.
Yep. Now, while I'm doing the presentation, I may not be able to see that chat feature. So Tom, can you monitor that chat feature?
Sure.
Okay. So I'm going to move into, I'm going to share my screen here. And this way you guys can see my presentation. Like I said, this is just meant to be 10, 15 minutes, 20 minutes tops, just to get the conversation started. Okay. So since March, we have been talking about nothing except the coronavirus. I do a weekly radio show here in Seattle, and all we talk about is the coronavirus. It's literally the only thing that's been consuming us for the past 8, 9, 10 months. Rightfully so. So what do we do here? What's going on with COVID? Well, first of all, I wanted to talk about a little bit about how COVID has affected my life, and it has. I was stuck in Europe for 6 months. I traveled to Europe in February to go to Poland. And lo and behold, the coronavirus epidemic struck sometime around March. And Europe was the second ground zero, essentially. So China was the first ground zero, and then Europe became the next epicenter of the outbreak. And Europe went under this harsh lockdown. And I was stuck in Poland, like I said, and Poland had a particularly harsh lockdown. You couldn't go within 2 kilometers of your house. Like, you couldn't leave this radius. Your house is here and you have a radius. You can't leave within 2 kilometers unless you had some, extremely good reason. Like, you had to go to the hospital, or you're going to the doctor, or you're going to the grocery store. That was basically it. So that lockdown was eased, thankfully, by April or May, and then life sort of resumed back to normal for a while. And I was able to come back into the United States in August. And I'm glad that I'm gone, because Europe is now re-implementing another tough lockdown. The first lockdown did not work. It worked temporarily to calm down the virus for a little bit, but then it all came back. And now Europe is in a real world of hurt, similar to the United States, really. The virus is kind of out of control there. The picture there that I have on that screen is what a hospital in Poland looks like. It looks like a lunatic asylum, and I just thought that was a picture worth having. So right now, what's going on with the COVID-19? Well, first of all, we've got about 72 million cases globally that have occurred. 1.6 million deaths in the United States. It's 16 million cases and about 300,000 deaths. Question is, how reliable is this data? And we're going to be arguing about this for quite some time. Some people say that we're overcounting the number of COVID deaths. Some people are saying we're undercounting the number of COVID deaths. The tests that we use are not perfect. Every diagnostic test has false positives, others have false negatives. So it's tricky. We don't really exactly know the exact count of people who are dead from COVID, or people who died indirectly because of COVID. For instance, let's say somebody is having cancer treatments, and instead of going to the hospital because they're afraid of getting coronavirus, they decide to pass up chemotherapy and they die of cancer instead. So does that count as a COVID death, right? Well, there's a lot of trickery and a lot of tough ways to measure deaths, and that's why the COVID death count is not particularly clear. My colleague, Dr. Chuck Dinnerstein, has a great example of this. He says, pretend that you've got, untreated hypertension, and then while you're driving your car, you have a stroke, and then you crash into a tree and smash your face on the windshield. So what's the cause of death? Is it the stroke? Is it the high blood pressure? Is it the car crash? Is it the tree? It's not exactly clear what the cause of death is. And when you have a death certificate has approximate cause of death, like, the tree killed this guy, right? Or a car crash killed this guy. And then that was triggered by a stroke, which was triggered by underlying cardiovascular disease. So that's how these death certificates are usually written. And I presume that if anywhere in that narrative COVID appears, then COVID is then considered a COVID death. That's my guess. But that gives you an idea of how death certificates are written, and they're not particularly clear exactly. Those narratives are nice and tidy, but they may not be entirely accurate. The most accurate data will probably come out next year, and that's when we look at what's known as excess mortality. And so we know in general how many people die every month of the year. We know that, just pick a number out of a hat, 60,000 people die in January every year, for instance. If we have 61,000 people die in January, that's an anomaly. You don't expect that. So those 1,000 deaths would be considered excess mortality. If you look throughout the whole year, you then can see whether or not more people died than expected. And that is something that the CDC will be putting out. The Center on National Vital Statistics will be putting out data like that. And this chart comes from the CDC. So you can see that up until about late February, early March, deaths were basically what we would expect. This black line here is the average expected number of deaths. And up until about late February, early March, the number of people who were dying in the United States was matching exactly what we would expect. And then something happened. The coronavirus pandemic happened. And now you can see that there is this spike in deaths above what we would expect. And if you look at all causes, so cancer, strokes, cardiovascular diseases, all that stuff, that also increased. And of course, COVID deaths increased as well. And so what we will do then at the end of when all the data is accumulated, and it takes a while to get this data. Data on death is actually not particularly accurate for about 6, 7, 8 weeks after the death has occurred, because it takes a while to accumulate all the data. So sometime in 2021, maybe early in 2021, we'll have a pretty good picture of the number of deaths that were either directly attributable to COVID because somebody got COVID and died, or indirectly attributable to COVID because somebody had a heart attack and couldn't make it to the hospital because all the ICU beds were filled. Okay. So we will have a better idea of the impact of the virus next year. I don't expect the numbers to be all that different from what we're seeing now. So when we know right now the number is 300,000 dead, I would expect something like that in the ballpark when all the numbers come in next year. Having said all that, the risk of death is wildly different depending on your age and on your sex. This virus discriminates. It's a sexist virus, and it's an ageist virus. Throughout almost all age groups, men are about twice as likely to die as women. And that begins in the 20 to 24 age group. You can see there's already a difference breaking out. So this is college-aged people. Men are about twice as likely to die as women, and that pattern remains for every age group beyond that. All the way up to age 80 plus, there's a 10%, 11% chance of death among men who are over 80 if they get coronavirus, but it's only about 5.6, 5.8% among women, so roughly 2 to 1. So that's one pattern to notice among these infection fatality rates. Another pattern to notice is that the infection fatality rate slowly increases. So if you look at the mean here, these, by the way, are listed in percents. So this is 0.003%, which means 0.00003, right? I mean, the likelihood of death for a child is almost zero, right? The likelihood of death for a college student is almost zero. So when you hear these scare stories in the media about, well, this young, healthy college kid came down with coronavirus and he was hospitalized and he almost died, that's rare. Okay, you're hearing something, you're hearing the scare stories rather than the vast majority of stories where they're probably asymptomatic or they got a mild cold and just didn't even know they had the coronavirus. Okay, those are the vast majority of cases for young people. As people get older, though, the risk of death increases concomitantly, and it goes very slowly. You can see 0.006, now 0.013, then 0.024, 0.04. So it's very kind of slowly increasing as we get older until age 65. And that's when a jump occurs. And it's a pretty substantial jump, really. You go from under 1% chance of death at age 60 to 64, about 0.5% chance of death, so 5 out of 1,000. And it jumps to 1%. Now, to me, anything that has a 1% chance of death is pretty high, right? I mean, would you get on an airplane that had a 1% chance of crashing? Probably not, right? I mean, so that's a pretty substantial risk of death at age 65 plus. And then it just keeps getting worse from there. 1.7%, 3.2%, and then by the time you're over 80, it's 8.3% chance of death. So what are we doing to fight back? Well, we've got this several vaccines, several different kinds, and the general mechanism of how a vaccine works is that you get a vaccine injected into your arm. And in this case, in this vaccine, you have these dead or weakened microbes, these little blue blobs. And immediately they are gobbled up by resident immune cells. So you have dendritic cells, which are the key cell that links what are known as the innate immune response, which is our kind of our generic immune response, to the adaptive immune response, which is the highly specific immune response that creates antibodies. So dendritic cells will link these two parts of the immune system together. This happens inside of the lymph node. That's why whenever you get sick, the doctor goes, show me your lymph nodes, right? Oh, okay. And then if they're swollen, you're sick. Why? Well, it's because of this. All of the cells that are in your immune cells have rushed into the lymph node and they are monitoring what's going on. These dendritic cells are showing what they've caught to the T cells and B cells, and these cells are then expanding and growing and responding, and that's why your lymph nodes swell up, because there's a lot of activity going on inside of your lymph nodes. These are like military outposts, right? Measuring what's going on throughout the body. So there's a lot of activity that goes on inside of a lymph node when you get sick. That's why they swell up. What then happens is that you have two arms of your adaptive immune response. Remember, the adaptive immune response is the highly specific immune response. Think of the adaptive immune response as assassins. These are people where you say, here's the picture, here's the guy, this is Osama bin Laden, this is the guy you want, right? Go get this guy. Whereas the innate immune response, they're sort of like the beat cops street, like who they're dealing with. They just, so they see a guy who's drunk and passed out on the road, and they capture him and take him to the police station. They don't even know if he's bad or not, right? That's the kind of the difference between these two arms of the immune response. The adaptive immune response then is itself broken down into two pieces. The first is known as the cytotoxic T cell response, and these T cells literally destroy your own body cells. What they do is they monitor your body cells for any sign of infection. And if it decides that you've been infected, it will kill that body cell, because there's really no hope for it anyway. It's been infected by a virus, no hope for it, so let's just kill that cell. That's what the cytotoxic T cell response does. The other more famous response is the B cell response, because these produce antibodies. And so when you go to have an antibody test, it's measuring what's being produced by the B cells. And these antibodies are highly specific for the virus as well. So if you test positive for an antibody test, this is why they can say you tested positive for coronavirus. Now, that's how a traditional vaccine works. How does the mRNA vaccine work? Well, it's similar, but slightly different. In a traditional vaccine, we inject you with antigen, okay? Antigen is anything that causes an immune response, okay? It could be a protein, it could be a bacteria, it could be a virus, it could be anything. You inject somebody with an antigen and you get antibodies. That's what an antigen is. In this case, and with a regular vaccine, we inject you with the antigen, all right? That's not what we do with an mRNA vaccine. With an mRNA vaccine, and that's on the right side here, so ignore the left side of the picture, just look at the right side of the picture. What we do with an mRNA vaccine is we take mRNA, which is think of it as a photocopy of your DNA. So the DNA has all of the instructions for how to build a body, or it has all the instructions for how to build a virus, right? mRNA is like a photocopy. You take the master blueprint and you photocopy it, and you have a copy. That's mRNA. So we take the mRNA, we put it into this little fatty bubble called a liposome, and that helps protect it. That's what's injected into your arm. What happens at that point is that your individual cells will then take up the fatty blob, they'll unpackage it, and then boom, mRNA pops out. Well, that mRNA that we put in there was viral mRNA. We did that on purpose. And then just like any other protein in the body, your cell will take that mRNA, which is a code, and it will translate it into protein, but it's viral protein, okay? It's a virus protein that we just gave it. And then it takes that viral protein and it sticks it out on the surface of the cell. That's also typical immune response sort of activity. But normally, it would be your own protein that it's sticking out on the surface of the cell. In this case, it's sticking out a viral protein. And that's how the immune response is triggered. Now, when immune cells come by this cell, they're going to go, whoa, what is that? That's not normal. Like, this is a normal, healthy cell that's bearing an antigen that we don't recognize. Where did that come from? And it will then start an immune response against the cell that's holding that foreign protein. That's the basis of the mRNA vaccine. It's experimental. It happened to work. Pfizer's vaccine is 95% effective. Moderna's vaccine is 95% effective. This will be, now that it's been approved on an emergency basis, these are now the first mRNA vaccines ever on the market. And so one of the benefits to these mRNA vaccines, you're saying, well, why do this? Like, if this process works fine, then why do it a different way? Well, the reason is because it's super easy to crank out mRNA. Super, super easy. It's a chemical reaction. You can do it in a test tube, or you can do it, with an automated sequencer or something. I'm not a sequencer, but an automated nucleic acid building device. These are really, really simple things to make, and they can make them at mass scale. And so, in a way, this is a better way to make a vaccine. Okay. And I think this is the last slide. Yeah. So which one's better, right? I mean, ultimately, that's what we want to know. We're going to have a vaccine here, and we want to make sure that we have the best one. Pfizer and Moderna, as you can see in this top graph, Pfizer and Moderna are both using that new mRNA technology, okay? Pfizer's an American company, Moderna's an American company, and AstraZeneca is a British company. The Brits have decided to go with the more traditional route, which is called an adenoviral vector. Now, those of you who've taken medical microbiology, and I would suspect that's probably all of you, the adenovirus is a fairly harmless cold virus. And they use an adenovirus from a chimpanzee, so it actually has really no impact on humans anyway. And they genetically modify it so that it expresses a protein that comes from the coronavirus. So when they inject that into you, they've injected you with a virus that really has no impact on humans because it's an adenovirus that comes from a chimpanzee, but it does have the protein that stimulates an immune response that comes from coronavirus. And it works, okay? But it doesn't work as well as what Pfizer's technology and Moderna's technology did, which is kind of a surprise. The efficacy of the Pfizer and Moderna technologies is about 95%. The efficacy of the AstraZeneca technology is only 62 to 90%. We don't really know why. AstraZeneca is really good at making vaccines, and it was kind of a surprise that their technology wasn't as good as the newer technologies. So I must admit to being surprised by that. I was expecting these to be maybe 50% effective, maybe, but didn't work out that way. One of the challenges with the Pfizer and Moderna vaccines is something known as the cold chain. The reason that you guys and me and all of us can eat bananas or peaches or strawberries any time of the year we want is because of something known as the cold chain. Food is grown somewhere else in the world. It's then harvested, put into a refrigerator, refrigerated truck, refrigerated airplane, and transported to wherever we are, and then taken out, put into another refrigerated truck, driven to the grocery store, and put into a refrigerator, right? That's the cold chain. You have to do this or the food goes bad. Same thing with vaccines. Vaccines have to be refrigerated. Unfortunately for Pfizer, the refrigeration we're talking about is like Antarctic temperatures, right? It's negative 94 degrees Fahrenheit. This is really, really, really cold. Like you don't encounter temperatures like this generally on Earth. And it's not really clear why that's the case, but they found that for their formula to be stable, it had to be stored at negative 94 degrees Fahrenheit. And on top of that, once you take it out of the deep freeze and put it in the refrigerator, it only lasts 5 days, okay? Moderna's vaccine has a slightly different formulation. They won't tell us what it is because this is all proprietary information. They have a more standard freezer. So negative 4 degrees Fahrenheit is like the freezer you would have at home to store your popsicles in, right? And ice and things like that. So this is a more standard freezer. And once it's taken out of that freezer, it can last up to a month in the refrigerator, okay? Finally, AstraZeneca's is the best, okay? It only requires a refrigerator the entire time. Your refrigerator that you put your lunch meat in and your coffee or whatever is 36 to 46 degrees Fahrenheit. That's all their vaccine needs. And it can last at 6 months at that temperature. So AstraZeneca definitely has an advantage here. Even though it's not nearly as effective, if you want to get as many people vaccinated as possible, AstraZeneca really got a leg up here in this regard. And then some other things. The price per dose for Pfizer and Moderna, they're looking to make a profit, which good for them. You know, capitalism works. Pfizer's looking for roughly a $20 per dose vaccine. Moderna's looking for a $32 to $37 dose per 30 price point per dose. But AstraZeneca has promised that it's not going to profit until the pandemic ends. And so they are offering their doses at $3 to $4 per vaccine. Keep in mind that this vaccine requires 2 doses. So each of these you'd pay twice, right? Assuming that you have to pay for it. In the United States, I think all these vaccines are going to be paid for by the government. So I think it's all going to be free for us. And then finally, how many doses are coming out? Because we're already starting to see stuff being shipped out. Well, how much do we have? Right now, Pfizer is the only one that I know of that's actively shipping right now. Pfizer says it will have 50 million doses by the end of the year. Moderna says it'll have 20 million, and AstraZeneca says 200 million. Now, keep in mind that these are not all going to come to the United States. The reason is because these companies have contractual obligations with, France and Germany and Japan and other countries that have all put in purchase orders, and they're going to try to ship these vaccines out to whoever they can, whenever they can, as each batch comes out, it's going to be shipped. Now, I fully expect there to be a political argument over this, right? Because Pfizer's an American company, and if you're the president of the United States, you're going to have a hard time explaining why the next batch of the vaccine is going to go to France rather than the United States, right? And so it would not surprise me in the least bit if Congress or President Trump or the incoming Biden administration says, you're not going to do that. Your contracts are nice, but you need to service Americans first. That would not surprise me at all. So keep an eye on the news for that, because I think that would be a pretty realistic and maybe reasonable policy for the American government to implement. So that is basically it. There are some other articles here. I don't want to monopolize your time. I want to give you guys plenty of chances to ask questions and to talk about whatever you want. But there are some other articles I've written that may be of interest. One of them is, why do so many nasty viruses come from bats? There actually seems to be a biological answer to that question. Then I have an article on the geopolitics of vaccine distribution, particularly on the fights that we're going to expect over vaccines. And then I talk about stay home and stay safe. Stay home, stay safe is actually a policy that's not particularly working very well, considering that now almost half, in some places anyway, almost half of new COVID transmissions are occurring within households. I also write an article about why the UK seems to be better at regulating healthcare products than the FDA. They actually beat us. I think this is embarrassing. The UK beat us to approving the Pfizer vaccine. Now, Pfizer's an American company, and the UK regulators beat us at approving our own vaccine before the FDA did. And then, if you aren't scared enough by coronavirus, the H5N8 avian flu has been spreading around the world. So if you'd like to lose some more sleep, you can read about that article. Although I'll give you a spoiler alert, it's probably nothing to be too worried about yet. And then an interesting article on MMR vaccines. It seems that people who have immunity to mumps. So mumps is the second M in the MMR, measles, mumps, rubella. People who have a good, robust response to mumps seem to not get severe cases of coronavirus. It's not known why. It's presumed to be some sort of cross reaction between those antibodies and the coronavirus protein, but it's an interesting observation. And that's all I've got for you guys. So now it's your turn to fire away.
You want to bring down the PowerPoint?
Oh yeah, for sure.
Okay. Does anyone have any questions? Like I said, you can unmute yourself by clicking across your image and hit the unmute button in the upper right.
Tom, this is Jeff True.
Yes, how are you?
Good.
Hi, Jeff.
Hi, Alex. Alex, is there any difference between the Moderna and the Pfizer vaccines that I should be concerned about? If I'm offered on a local level to get one versus the other, do I just take whatever comes along? Or they should be approximately the same efficacy, or should I even bother to wait for a Johnson where there's only one shot needed?
I take the position that if you have the ability to get the vaccine, you should get it. And but there's a caveat to that. If you're going to get the vaccine, get the same dose of the same vaccine twice. So don't get one Moderna shot and then one Pfizer shot, right? And the reason is because they're probably working on slightly different antigens. And so the point of a booster shot is to give your body a second chance to recognize that antigen and to really go after it a second time. But if you change vaccines, you may be using a different antigen. And so if you're going to do it, get the same shot twice. And I don't suspect any reason to believe that Moderna's vaccine is all that different from Pfizer's. Let me give you a secret. if Moderna had been the first one to get their vaccine approved, I would not have gotten the vaccine. Okay. And the reason is because Moderna is a brand new company. I'd never even heard of it until earlier this year. It's a new company, a new technology. I would have waited to see what would happen. However, what changed the game for me was when Pfizer came out and said, we have the same kind of vaccine and it also works. Now, Pfizer, this is the filet mignon of pharmaceutical companies, right? Pfizer is huge. They know what they're doing. They're very good at this. And the fact that they came out with the same technology, with the same efficacy, now I'm convinced that Moderna's vaccine is just fine as well. So I think you're good to go with whatever you get.
And Pfizer not only has a history of producing ethical pharmaceuticals, but also vaccines.
They specifically are a major vaccine producer, right?
Yeah. AstraZeneca is also a very large vaccine producer.
Yep.
Okay, thank you.
Anything else? Any other topics, science-related topics?
Yeah,
like I said,
ask
Alex,
about anything you want. This is really for you guys. We're doing this for you. So you want to talk about
I have a
fracking or Josh Bloom's weird articles? I mean, whatever. Whatever. Josh isn't here, so we can trash him, while he's not here.
Ed, Keston, I apologize for coming on a little late, but staying with COVID for a moment and the excess deaths chart that you had up there, I have seen some stuff on internet. I don't know which exact source that looking at that data over very, very long periods of time and noticing that it's basically a sine wave year after year, that some years there's excess deaths, some years there's less, under normal averages, right? There's no such thing as a flat line. And that in fact, the years leading immediately up to the COVID experience was an under average, if you will, death year. And so there was a lot of quote unquote dry tinder, not my expression. And that added to the size of the peak that we saw because people who might have otherwise died, and it was attributed to COVID. And that the second hump in the United States in particular was specifically due to the different, the United States is a big place. So that you have very, very different climates. The Northeast led, and then it traveled across the country, and that the climates would have been expected to have that second kind of peak. So getting to my question is, are we actually in a third wave here? And I feel like excess deaths is the right measurement, not necessarily cases, because this guy uses the expression case-demic. It's not really that important, but excess deaths are. So I'm just curious if you have a feeling about, are we in the third wave? Is it really that bad, or is it still?
Yeah, so I had been looking at the European Centers for Disease Control, which is basically the EU's version of the CDC, has been collecting death data on all 57 countries or something that they claim some sort of jurisdiction over, that are European countries. And they collect data all over the world. And the United States is very, very clearly in a third wave. Europe is going through its second wave right now, but we had a wave at the beginning of the pandemic. We had another wave in the summer when Europe had gotten their virus under the control, and they were celebrating. And in fact, the Czech Republic actually threw a party on a farewell to the coronavirus. Well, oops. Right? The virus came back. And so Europe missed its second wave when we were going through a second wave. And now Europe is going through its second wave and we're going through a third wave. Your point about what you referred to as, a lot of dry tinder, of course, this is an insensitive way of putting it, but it's true, right? That thanks to modern medicine, we have a lot of people who are alive. Thank God, a lot who are alive who maybe necessarily wouldn't be alive. But when something like coronavirus comes along, it tends to hit those people pretty hard, right? And so, it would not surprise me if next year we see a lower level of deaths, or 2022 we see a fewer number of deaths than we would expect, precisely for the reason that you just said, which is a lot of the people who are kind of the low-hanging fruit for a virus were already killed by then. So yeah, it'll be interesting to see what the mortality statistics are for the next year and in 2022. I think you make a very interesting point.
The total death rates, by the way, for the year, some states take longer to report to the CDC, and so we could not, it's possible that we won't see the total death rates for 2020 until sometime around May or June of 2021. So to keep that in mind. One little thing I sent Alex yesterday, I did some research looking at the old Spanish influenza from 2018. At that time, the U.S. had 675,000 deaths from Spanish influenza and a population of 103 million people, for a total death rate within the population of 0.657%. COVID-19 U.S. death rates are 302,000 with a population of 331 million, which makes the death rate per total population of 0.09%. The measures taken during the Spanish influenza are different than the ones taken in the U.S. The ones in the U.S. have been administered primarily by governors making the closures, whereas in 1918, those were primarily done by mayors, not by governors, and none at the federal level. The measures taken in most cities included lockdowns of larger gathering spaces like churches, theaters, schools, and public gathering spaces. And they issued mandatory face masks to be worn outside of the home at all times. Penalties ranged from $10 fines, which was more than a day's wages back in those days, to being shot by public health officials. Four people not wearing masks in San Francisco were shot by San Francisco public health officials. That was from an article in the National Geographic.
That's fantastic. Public health officials could just execute people on the spot.
So, and then to take a look at the current COVID in the U.S. versus worldwide, the U.S. has 16.6 million cases with 302,000 deaths, for a death rate of those infected of 1.89%. Worldwide, there's 72.8 million cases, 1.62 million deaths, for a death rate of those infected at 2.2%. So the American healthcare system is doing very well compared to the rest of the world in keeping those who do get infected with the disease alive. When the disease first hit Europe, the fear was we weren't going to have enough ventilators, and the Italians particularly were, as soon as you were diagnosed, they were throwing ventilators into people's lungs, and that turned out to be a bad thing. That was helping to quicken the pace of the deaths. And so in the US, when you go into the ICU, they don't automatically put in the ventilators now. So we actually have a surplus of ventilators because we did, Trump did urge manufacturers to pump up the number of ventilators. So we now actually have a surplus of ventilators, not necessarily a surplus of ICU beds. And some hospitals have more patients than others. I know that a New York Times reporter had said that South Dakota had all their hospitals at 100% capacity for their beds, particularly in the ICU units. And Governor Kristi Noem, who's the only governor that had no lockdown in her state, she went and contacted each of the hospitals in South Dakota and found that on average, they only had beds at 40 to 60% rates. So there has been a lot of false reporting on just how severe the virus has been. I'm not downplaying the deadliness of the virus, but I am just pointing out that there are instances where they're trying to use fear-mongering techniques to make us go into panic mode rather than do the things.
One thing I wanted to hit on, Tom, that you had mentioned was back during the Spanish flu, it was mayors, not governors, that were dictating whether or not there was a lockdown.
Right.
And in the state of Washington, so I live in the Seattle area, our governor is not the brightest crayon in the box, okay? And he implements a statewide lockdown. And so you can only grab food. It's only to go. You can only go to a restaurant, grab food, and leave. You can't stay there. And that's the policy, whether you're in Seattle or whether you are in little tiny Waukegan County in near Portland, Oregon, which has had a whopping total of 11 cases and no deaths. And yet they're under the same policy that Seattle's under. And this to me is precisely the sort of nonsense, baloney, bad policy that ACSH exists to fight against. It makes perfect sense. If Seattle wants to close down because there's too many coronavirus cases, great. But why would a little town that has no coronavirus be forced to shut down as well? And this shows that government, in some cases, that the policies they're implementing are just not well thought out. And it's been a source of tremendous frustration here in Washington State. There's actually now restaurants that are openly defying the governor's orders because they're tired of it. And we've lost in Seattle about 20% of our restaurants permanently. And so this is going to have a substantial toll on the economy once the dust settles. This is going to have a really big impact on our economy. And something that we aren't talking about is I anticipate a wave of municipal and state bankruptcies coming up in the next year or two. And we've got a real mess to walk through, and we're not really talking about the economic impact yet as much as we ought to be.
I have Bill Greaves. I'm in the Milwaukee area, and it's interesting that the Milwaukee County Medical Examiner, pathologist named Peterson, has stated that he is only counting, true COVID cases. He is not ascribing. He's being very careful about calling a death a COVID death. And he's not ascribing, or he is using other causes of death where COVID may have just hastened an underlying cause, getting back to your example, Alex. And he's taken some heat as a result of that. And he has come out and he said, well, his job is to be scientific and, damn the torpedoes, he's moving ahead. So I applaud him for that. It raises the question about how we're going to know, later next year what the true cases are. Because if a lot of places are still, calling deaths that should not have been ascribed to COVID, it comes down to, your methodology and everything. It may end up taking, a bunch of retrospective studies in different areas to try to get a true number. So a true number may be coming down the pike in, a few years from now. It may actually take a while.
Yeah, that's a good point. If you're looking for deaths that were directly attributable to the virus, that number is going to take a while to get that number.
Yeah.
But if you look at just how many extra people died during the pandemic, we should know that probably within 6 months or so. And that would include everybody, right? And anybody who died earlier than we expected for whatever reason will be included in that number.
Yeah. My other, I did have a question regarding the number of cases based upon positive tests, because, and I wonder if anybody has looked at how many individuals are getting multiple tests to see when they turn negative.
That's a great question, and I don't know the answer to it, but I personally know of people who've gotten multiple tests, right? So if they've turned positive 3 or 4 times, are they counting that as 3 or 4 cases? Right. That's a great question, Dr. Greaves. Very good question.
I've been tested twice and both times were negative. One was for surgery, and the most recent one that I had last week is because my mother-in-law is 87 years old. My wife and I are going to visit with her, and my wife wants to make sure that we're okay before we go up there. As people age, their immune system weakens. They're on drugs that weaken immune systems further. And I firmly believe that one of the reasons the elderly are more susceptible is because as you age, your immune system deteriorates. And that's why these vaccines are so important, particularly for the elderly, because it will help reinvigorate their immune system and have it focus on attacking this disease. That's critical. And
Actually,
so,
you know, any vaccine that you get sort of boosts your immune response in general. That if you get a flu vaccine, your whole immune system sort of gets a perk, and you know, you're less likely to get some other disease that's not even related to the flu. The vaccines seem to have a kind of an overall boosting effect to the immune system. So it's always important for people to get their vaccines if there's one available.
and sunshine.
And sunshine.
Sunshine's help. That's why during the Spanish flu, most of the people being treated during the summer months were moved to outdoor beds so they could sit in the sunshine.
There does seem to be something to that.
And exercise helps with your immune system.
Although when you have the flu, exercise doesn't seem to be something you really want to do.
Well, and then you could be like my dad and take 10,000 IUs of vitamin D every single day for the past
So, you know,
30 years.
one time a few years ago, I got so sick that I felt like I'd been hit by a bus, and I could barely move. I couldn't get off the couch. And I thought, well, this is what the flu feels like. This is the flu. And I finally scraped myself off the couch and made it to a clinic. And I said, I've got the flu. Can you guys just confirm it for me? And, you know, I'll be on my way. And they said, no, you don't have the flu. You've just got some virus, sorry. And I thought, wow, like, you know, and so no wonder people get so confused about whether or not they have a cold or the flu or the coronavirus, because really the symptoms are all the same, right? You have to have a diagnostic test to know whether you had the virus. And so that's just an interesting personal anecdote that I realized that now you can't really tell the difference between the symptoms. Yeah.
You made me think of something, because I just heard yesterday that they're going to have an in-home test that you can buy commercially. So there goes all your case data, correct? Who's going to report?
Yeah, very good. Yeah, even worse, right? Because who's going to report that? Who's going to call the public health office and tell them, right?
Well, Abbott Labs does have a rapid test. It takes about 30 seconds to determine whether or not you're negative or positive. And one of the conferences that I attended last week, they were pointing out that they're very cheap. They're $1.60 a piece. That restaurants could just have 100 of these at their front door, and as people want to come in and eat, they could just take the test, and if they tested negative, let them in, and they don't have to worry about wearing masks. They don't have to worry about anything because everybody in the restaurant is COVID negative. And so that's how we could return to normal at a relatively inexpensive cost.
My story has an interesting epilogue to it as well. I was supposed to get on an airplane to fly to Portugal the next day. Okay. And the doctor told me, you know, I don't think that's a good idea. And I said, you know, I'll survive. I'll do it. I'll tell you what, if you have a bad cold and you get on an airplane, it feels like when the pressure changes in the room, in the cabin, it feels like someone blew out the front of your brain with a 357. I have never experienced pain like that in my entire life. So they were right. I really should have rescheduled that flight, but I learned that one the hard way.
Although we did do a report about airplane airflow, and the air in airplanes is actually cleaner than the air in most buildings, because what they do is they take half of the air that's in the cabin. It goes through very dense filters that filters out almost everything, including viruses and things like that. And then they pull in air from out. Half the air comes in from outside the plane, which is sub-zero air. So there's no viruses in that are living. And that's what comes into the air. So the airplane air is actually very clean. The only thing
and the ventilation then is down by your feet. So if you're coughing or something, it's not likely that the stuff's going to spread out that way. The air's coming down and goes down that way and out through the bottom of the airplane.
Right.
It's actually, if you'd rather be, if you have a choice between an office or an airplane cabin, you're actually probably safer in the airplane cabin when it comes to getting a new infection. Tom's right about that.
And then the other thing that we came out with, Alex did back in January, was looking at surfaces in airplanes. If people do have a virus or something like that, and they touch the tray and they touch the seat in front of them and they touch the handrails and all that stuff, it does leave behind small traces of disease and viruses and all kinds of things. But by putting in a few black lights, when the plane is empty, if you throw the ultraviolet light switch for 30 seconds, you kill everything that was on surface contact. So, well, you don't kill it, you neuter it so that it can't reproduce. That's what ultraviolet light does. So that's another way to attack it. I know that some of the home HVAC companies are now putting in ultraviolet systems into the systems that they're installing in people's homes, so that as the air flows through, it gets zapped with that ultraviolet light and then goes out into the rest of the house. So you're getting much, much cleaner air.
But Boeing has now created self-cleaning UV light containing bathrooms for airplanes, so that when you leave, the UV light turns on and it sterilizes the room, which I would imagine now is probably in high demand following coronavirus.
I have a question.
Sure.
It goes back to comments you made a while back about the multitude of viruses that are capable. And I'm not very astute on the science, but I learned from somebody who was close to one of the infectious disease laboratories of the government, who got very interested in the subject of this virus in January and February. And the first thing they did was they essentially synthesized it themselves so that they would have their own version COVID-19 that they could then work on. And they created that by going to the platform on which many of these viruses exist, or at least the pieces of them exist. And I guess in my uninitiated form, I'd say you take this little piece and you move it from down the platform to here and you create COVID-22 or 17 or whatever. And in effect, you can synthesize a whole range of coronaviruses off of this platform. If that in fact is true, it raises some questions to me. Is the facility in which new ones will be coming at us more and more? And it also raises the question of the Wuhan laboratory. And was it bats or was it synthesized? And could this become a strategic factor in world domination going forward if in fact it can be done as readily as what I learned was done back there in January or February in our own laboratories?
Great questions. So I've got several points to make on this. The first is that, I'm not familiar with the story that you had just mentioned, but let's assume that it's true. It is not particularly easy to build a virus from scratch. This cannot be done. It's not going to be done in someone's garage. Okay, this takes an effort that's going to be at a university or in a sophisticated laboratory. Okay, it's not going to be something done, probably by ISIS or Al Qaeda. It's unlikely. Okay. The second thing to notice is to note is that we really can do this. The University of Washington, which is my alma mater, down about 30 minutes from here, where I got my PhD, Very controversial experiment. They resurrected the 1918 Spanish influenza based on its sequence, okay? And they constructed it, put it into a cell line, and boom, out popped the virus that killed millions of people. They did it, okay? It can be done, all right? So you're right about that. It caused an ethical storm in the biomedical community. It's like, why did you do that, right? Because was there something useful that you learned from this process, right? Another group resurrected horsepox, which, as its name implies, infects horses and causes like a smallpox disease like in horses. Again, the question was, why did you do that? Like, you know, what if this hops into humans? Like, why did you do this? And in cases like that, I like to quote Jeff Goldblum's character from Jurassic Park, which was, you know, we were all concerned about whether or not we could, that we never stopped to wonder if we should, right? Because some of these things are sort of dangerous things to toy around with. Now, having said that, if these then are then tightly controlled and used for research to understand why is the 1918 flu, why was it so deadly, that can yield some useful information, but it comes at the cost of being sort of a dangerous experiment to do. Now, your question about the Wuhan lab, the genetic sequence of that virus does not indicate that it was genetically modified. The reason scientists came to that conclusion is that if you were going to engineer a virus to infect humans, the sort of sequence that you would have predicted based on algorithms that would say, okay, do this, do this, do this, do this, and you'll probably infect a human. That's not the sequence they found. They found some other completely unexpected sequence. That would indicate that it was probably trial and error. And what is the best at doing trial and error? Natural selection, right? It's probably a virus that was in wild animals, process of evolution occurred, and out popped a virus that just happened to infect people, and it came up with a sequence that nobody expected. That's my personal conclusion on it. I think that's the likeliest explanation. It would not surprise me at all if it came from the Wuhan lab, because they had isolated the virus and were studying it, and they had a big mistake and somebody got infected. That is, I think, maybe the most likely explanation.
But could it be done if the wrong people, I mean, we pay countries billions of dollars not to expand their nuclear operation. Will we end up spending billions of dollars to keep people from fabricating the next one?
Dr. Greaves, you have to go? Okay.
Actually,
you know, I don't know, Tom. That's a great question. What I think that we're going to have a reckoning with over the next several decades is that biological warfare is a real thing. It's a real threat. On the flip side, the problem with biological warfare is that you can't really control the virus once you've released it, right? It's not like a chemical weapon where you can fire a chemical weapon at an army or at a downtown area, and the chemical kills people there, and then it eventually kind of evaporates and goes away. That's not how a virus works, right? You very well could kill your own people with a virus that you release. And so from a strategic standpoint, I don't know if biological weapons are the best military strategy because of the potential that it comes back to kill you. So I don't know. I fear conventional weapons than I do biological weapons, but you never know. It will always be a possibility, I think, in the back of our mind.
We have time for one more question.
Yeah.
Anyone else? Okay, and you know, if you have any other questions at any time, you can
Email
always
me.
feel free to email us.
Yeah, I'm at alex@acsh.org.
Have you ever heard of a chemical and ingredient called triethylene glycol, TEG?
Triethylene glycol. That's a question for Dr. Josh Bloom, I'm afraid. He
Okay.
probably has heard of it. What, do you have a question about it?
It's a sanitizer and it can be a disinfectant. It's been around for, I don't know, 60, 70 years. I'll follow up with you. I'm just curious. about
Okay.
it.
Sure.
It's out there.
You can always check it with Josh. Josh knows all those things.
Does he?
Yeah, you can CC Josh on it as well. What's his email? Is he josh@acsh.org or is he
Yeah.
Jay Bloom?
I think
Okay.
he's Josh.
Yeah.
Josh at ACH? Okay.
ACSH, yes.
Well, I will just want to say that I really had a thoroughly enjoyable time doing this. I really appreciate you guys showing up. Every month you're going to get somebody else. I think next month will either be Chuck or Josh, and then the month after that will be the other guy, and then the month after that I'll be back.
Well-
Maybe we should do one with all three of us at one point. That could be fun too.
Well, we also have almost 300 scientific advisors, and we can also ask them to participate in these things too.
Yep. Excellent point.
So it's, but it was good. I thank you all for your time, and I thank you all for your support. And I hope you enjoyed it and walked away knowing more about things than when you arrived.
Stay well. Stay safe.
Yep.
care.
Happy holidays, everybody, and stay safe. And we'll see you in January.
And let's hope 21's a lot better than 20.
No kidding. Bye, everybody.
Bye.